just go ahead and try to get started so we can stay on time.
Yeah,
so thank you everybody for coming.
To do, and I'll
appreciate you joining the breakout session. My name is Steve Kirsch, I'm the Executive Director of the York Reform Value Network. I just wanted to quickly introduce this breakout session. How to create and run a cash-based specialty practice. Great group of speakers today. Dr. Demetrio Aguila from Total Pain Solutions by Healing Hands of Nebraska. Sorry. Dr. George Lazude, Movement Orthopedics Institute, and Daniel Paul from Easy Orthopedics. So with that, kick it over to you guys.
All right. Thank you very much. So the format for today is going to be probably a little bit unconventional, but as all of you know, we're all here because we're unconventional, right? In our practice, we like to pride ourselves on being radically unconventional. So the three of us have separate practices, and I'm just going to do a quick introduction of myself. I'll leave the other introductions to Dr. Azude and Dr. Paul, and we'd like to actually make this a really free-form, open forum, and have you guys ask questions. Because I noticed last year when I came, I can't tell you how many surgeons came up to me wanting to pick my brain, and I said, you know, let's do this in a more, thank you, let's do this in a more formal setting. So my name is Demetrio Aguila. I'm a peripheral nerve surgeon, an ENT surgeon, a plastic surgeon in Omaha, Nebraska. I have been in practice on my own for the last 6 years, and I don't have any insurance contracts, and you know, I was very happy to give the bukas the finger.
Yeah, good morning, guys. Good morning, guys. Like Demetrio said, I think this is really important for us to just set the table and give you kind of an outline of what we do, and hopefully that will generate a lot of questions because, you know, the surgical side of the whole direct care and direct pay movement, it's not quite as clear as the primary care side, right? And so I think there's a lot of room for growth. We're still figuring a lot of things out. So I'm really happy to just set the table, kind of tell you on a 30,000 foot view of what I do and how that might generate questions, and I'm happy to continue the conversations now or even later on throughout the rest of this conference. So I'm George Azude. I'm an orthopedic surgeon based out of Houston, Texas. I have an orthopedic practice that's private practice, solo practice. I'm 100% cash pay on the physician fee side. And so that means all my professional fees, whether it's in the clinic or in surgery, are paid in direct cash pay. And I've been practicing for 2.5 years. Before that, I was employed with the University of Texas, practicing in an academic/community setting for 7.5 years. So that's kind of the perspective I'm going to bring here. I'm the one who started out of training in a traditional employee practice and then transitioned into a direct pay surgical practice.
And my name is Dr. Daniel Paul. I'm an orthopedic doc based out of Colorado Springs. My practice is called Easy Orthopedics. And again, I have a solo practice, orthopedics. I don't take any insurance at all. I don't deal with that in any sort of way. I'm mobile. I'm 100% mobile. I'm still that way. So I use my office. Well, I don't have my own office. I use other people's offices, and I'll do house calls, and I do all that kind of good stuff. So it's been about 5 years now. I started pretty much right out of my training. So we all have sort of different perspectives, and you'll find that each of us has our own brand and own way of doing it as we're kind of figuring out like our value add and like our value proposition in this different sort of world.
There are some empty seats up here at the front if you guys want to come and take a seat. That way you don't have to be, you don't have to hold the wall up. So, who has questions? I mean, obviously you're here because there was something you wanted to hear. If you don't have questions, I can kind of start us off with one. But if there's somebody who has a burning question out there, Dr. Danucci, please.
This will be for all three of you. How do you determine your base care?
So for those that didn't hear, how do we determine what we charge our patients?
Well, I think you make it up, and like if it's the right price, you know, people. So the doctors have two problems when setting prices. One, obviously, people think, oh, the price is too high, nobody will do it. But also, if you set the price too low, nobody will do it either. They'll think there's something wrong. So if you price your visit for less than like a copay, you know, people are going to like, I don't want to see this doctor. Why is this visit only $30? And they assign a low value to it. So you kind of sort of have to find that sweet spot of what makes sense and not devalue yourself. If it's too high, like again, people won't use it. If it's too low, they won't use it either. But it's some experimentation, looking at people around you, what they're doing. But if you're the only one in the market doing it, you know, you sort of have to just try and see.
I agree with that. I think you need to start somewhere. It did help me to kind of employ some free market, fundamentals. You look at your competition. So if there's nothing in your direct area, you look around the country. So I'm really happy that Surgery Center of Oklahoma existed. That allowed me to start from somewhere, right? And then you can work from there. You obviously have to consider different cost of living in different states and different areas of the country, but at least you start from somewhere. You have some basis to go from. So that's what I did. I looked around the country. I was actually surprised to find how many other free market, transparent cash pay opportunities and outfits that were out there. Don't get me wrong, there are not that many, but I didn't think there would be any. And so there was still something to refer to around the country as far as starting points, and that's what I used. And I really focused on Keith's outfit. Since he had orthopedic surgeons coming to his facility, I used that as a lot of my reference point to make my pricing.
Thanks, Dan. So, I came to this question when I first started my practice. I used CPT codes and E&M codes and RVUs, all the stuff that most of you are familiar with, and trying to figure out how am I going to price this. And I came up with this really complicated formula, which really did, it in some cases would take 4 hours, literally 4 hours to figure out how much to charge a patient for surgery. And I was like, this is ridiculous. And finally, one of my friends who's an attorney, and yes, some attorneys have friends, one of my friends who's an attorney said to me, Doc, he said, can I ask you a question that is likely to be offensive, but I'm not trying to offend? I said, look, we've known each other for years. Nothing you're going to say is going to offend me. And he said, what's up with these codes? I said, what do you mean? He goes, like these CPT codes and E&M codes and ICD-10 codes. I said, well, that's how we figure out, the value of our work. He goes, well, I don't understand. He goes, why don't you just do what we do? I said, what do you mean? He goes, look, I have an accountant. I pay that accountant by the hour. I have an attorney. I pay that attorney by the hour. I have a plumber that I pay by the hour. All I do is I take my hour, I take my time, and I multiply it by my expertise, and I tell my client, this is what I'm worth. Is your problem worth the same thing? If the answer is yes, then we move forward. If it's not, then we shake hands and say, okay, have a good day. And so that's basically what I did. To put it really simply, I took the gross overhead that I needed in order to run the practice. I did a little bit of math on that. I divided that by 2,000. Why 2,000? If the average American works 40 hours a week, 50 weeks a year, taking 2 weeks of vacation, that's 2,000 hours. And then I came up with my hourly rate. Boom, done.
I can also add, before we get to the next question, I can also add something else that I use. I use data on what a average orthopedic surgeon in the traditional model generates for a hospital system or a group. And I found that number to be about 3.5 million. And then I thought about what my practice looked like when I was in academics, 40, 50 patients a day in clinic. And then what did I want it to be? Maybe 10, 15, something where I can spend more time with the patients. So now I'm reverse engineering. If 40 or 50 patients generated 3.5 million, what would 10 to 15 generate? So then what now can I base that number off of, right? Take the certain percentage of 3.5 million, maybe it lands at 1 million or 1.5 million, 2 million. Consider the overhead, how much it's going to cost to run the practice, and how much I want to take home. So I use a little bit of reverse engineering to figure out kind of what I wanted to take home, what I wanted my overhead to be, and then start to figure back from that how many patients you need to see per day, how much you need to charge per patient, how much you need to charge per surgery, and how many surgeries you expect to do. So a little bit of reverse engineering as well.
You guys did more work than me. I just made it up. This seems right. We'll see what happens.
I think, can I add to that, Dan?
Yeah.
So I think, Dan is not incorrect in saying what he said. But the one thing that I think, the assumption that the three of us have made in this, and I think we should probably make explicit, is that ultimately, who decides what we get paid? The patient.
The market. Yeah.
Okay, the market decides. If I decide I'm going to charge $5,000 an hour for my services, how many patients am I going to have? Not very many. Yeah. I don't think my mom would pay that. Okay. But if I charge $100 an hour for my patients, I'll have more patients than I know what to do with, right? And so, I think Dan's right. You pick a price based on whatever calculations make sense to you, and then you see what the market can sustain. And if you find, holy crap, I got a 6-month backlog, well, then that's how you got room to raise those prices. If your backlog is 6 minutes, well, you should probably lower those prices.
Great point.
What other questions can we answer? I know there's some out there.
There's a question right there.
Sure. Mandy and Todd Rice, we're anesthesiologists and surgeons. We're in Hot Springs, Arkansas of late, and we just opened her independent surgical practice, which we're titling Direct Surgical Care of Hot Springs, kind of modeled somewhat loosely after DPC.
We're manifesting. We're not
Yeah, we're doing good.
That's great.
So we've got to take third-party payer because we can't pay a bill right now, but we're pushing everywhere we can, cash, talking about cash pricing, transparent pricing. But we can't get those patients. Our referrals are all coming through networks that are insured. And so how do you get access to those cash patients? And where do they get the money to pay?
So what I can tell you is that 50% of my patients are actually fully insured. And so I get a lot of calls, inbound calls, and the majority of them have insurance. And actually, it's an educational process that starts from that phone call. I explain to them what the cash pay model is. I explain to them that it's the professional fee, not necessarily the whole, episode of care. So MRIs, x-rays, surgery, facility fees, implants. Once I actually start explaining that to them, a lot of them, it actually clicks and they say, okay, that's not that bad. So I guess my answer to you is you don't necessarily only have to just focus on the patients who are just cash pay or uninsured. Some of them a majority of them can be fully insured. And it's just a different reason that they come to see you, and it's just the educational process.
Do they take your super bill and then submit it separately?
Absolutely. That's part of my education. I tell them, even though I don't submit and I don't interact with the insurance company, I'm happy to do, courtesy billing. So I'll generate a HCFA form off of my EMR and I'll hand it to them. That's their property along with their medical record. And at that point, they can take that to their insurance company and fight all they want. I also explain that they can call their insurance company ahead of time before they see me, find out 2 things. If their insurance company will pay them back at all and how much. And then if they like the answer that they get, then they can come and schedule an appointment with me. So some alternates, just alternate ways of thinking about who your patient population that you want.
With that, are you finding though that even if they don't get reimbursed for that, can they at least take it against their deductible?
That I don't know. That's a good question, and that would be a good educational point to learn.
Bills. One, the Senate bill I think is $1380, and then HR 820. They're trying to make that mandatory.
That would be huge.
Yeah, because they won't let it add on.
Yep.
And I would just say too, in system, the value of a doctor, we kind of know what it is. Like we kind of know what an ortho doc does, what an anesthesiologist does. But once you get out of the system, we're having to sort of redefine those value propositions. So if you take primary care docs, their value proposition in the system, we all have a good idea what they do, but direct primary care docs who are pretty well established, they do different things, right? Like they keep more stuff, they send less stuff out, they're doing a lot more. So I think that what I've been trying to do is figure out what does that look like for an ortho doc, specifically me, outside the system. And it's really pushed stuff more towards non-operative treatment when I can. So while in the system, everything's pushing you up to just do the surgeries kind of at the top here, there's this whole base of the pyramid that you're kind of sort of ignoring in the system, while you're just looking for surgeries that I think would help, a lot of people that don't want surgery, and then it also generates a lot of revenue in those base things while your surgery center is getting going. And then also as far as cash payments, I think if you can open for me, I define it as not necessarily just cash. As long as I don't have to interact with an insurance company, it works, whatever that means, right? Whether, it's a business paying me, some weird contracting thing through Department of Defense or whatever it is. If you can open yourself up to that, it's all functional, at least for me, as long as I don't have to interact with an insurance company. Once that happens, then the wheels fall off and it fails because I don't have the resources to do that. So I would just say keep an open mind about sort of the rest of it, because the direct pay surgical market is not the easiest market, but there's a whole host of people that you'll be stepping over if you just only focus on that.
Great.
Do you all participate in the platforms like Coral,
Yes.
Fair Market Health, and Zero Card, and
Empty sales.
So, yeah, this isn't working. Okay, so I'll start with that real quick, and then I'll hand it off to George and Dan. I started out working with MD Save, and I don't know if there's anybody here from MD Save, but what I'm about to say, they're probably not going to like. Okay, so when I started working with MD Save, they were very interested in price transparency and free markets. I'm in the Omaha area, and then within about a year of working with MD Save, they signed an exclusive contract with CHI. And they said nobody else is allowed in this market to participate with MD Save unless they're affiliated with CHI. And so I was grandfathered in. The procedures that I had already put on MD Save, I could continue to do through MD Save. But if I wanted to add anything else, or if I wanted to add another facility where I wanted to work, I couldn't do that anymore because the contract they had with MD Save, that CHI had with MD Save, blocked everybody out. So a word of warning when, specifically as it pertains, and I had a long conversation with the president and the CEO about this, and I was very, very pissed off, as you might imagine. And he said, look, I can't turn away that money. So these influences do exist, okay? Yeah, and let's not be naive. Let's make sure that we go into this with our eyes open. Now, I do work with Fair Market Health and Misha Health, and I'm excited about those partnerships. I also did some work with Best in Class Care, and I'm excited about these opportunities. We just recently started working, and so I don't know what the fruit of that's going to be yet, but I am excited about that.
I won't go into depth, but I'll kind of echo what Demetrio said. I do think it's maybe a matter of evolution. There's still more time that needs to be kind of laid out before these, I call them online marketplaces, evolve to the point where they have enough, clients on the, buying side versus physicians on the provider side. 'Cause I'm signed up with several of these marketplaces.
Yeah.
So MD Save, Savo, Sesame. There are a few folks that are at this conference, Mishi, Health Me. I think it's a matter of, time, but right now I have not seen any volume from those, so zero volume from those marketplaces.
Yeah, same with me.
So,
Yes.
Are you affiliated with any DPCs at this point in time for any?
so I'm not affiliated with them, but I market to them. That community is small but growing in my market. And I do traditional marketing rounds to them. So I go to their facilities, shake hands, get familiar with them. I have a DPC. I use Sedera Health. So I'm tapping into that ecosystem, personally, because I truly believe in it. And so, yes, I'm definitely going that route. I think there's some other routes as well outside of just DPC that Dan has used.
Yeah, so I mean, for me, DPC, I use it for myself. The same thing with Dr. Ozude. I actually use Sedera as well. And what I've found is it depends on the DPC doc, because you would think that they would be your best referral source, but they're often not. At least for somebody like me. So sometimes they'll kind of get it and they're like, this guy, I've had one and she works with a big company and she basically sends me all her ortho. It gets billed through the company for small surgeries. It's really good. But I've had others where I've known them for 4 years and you get nothing. And then you find out the stuff that they're keeping is kind of wild, at least in my opinion, from a musculoskeletal standpoint. So I think their value proposition, it's also about defining these values, is not sending out in a way, because that's how they define, I take care of everything. And I think they sometimes should send out when they don't. So oddly, they're not really the best referral source if you're in the direct specialty space. At least for me in the world of musculoskeletal care, I've had a far easier time getting referrals from chiropractors, who are probably actually my best referral source. And if you think about it, it makes sense. They do cash, they do all musculoskeletal work, they don't really do extremities. It kind of works perfectly. But that's been my personal experience with DPCs. If you get the right-minded one, they'll send a lot to you. But if they're not thinking like that, you're going to essentially get nothing. And that's been more common than not.
My experience with direct primary care practices, well, let me start by saying, is Brent Holmquist here? He was going to be. Okay, so he's my direct primary care doctor, and he's here at the conference. I feel pretty strongly that if you're gonna preach this message, you got to walk the walk, right? And so, just like Dr. Zude, just like Dr. Paul, my family and I have a health share. We gave insurance the boot. We use Zion Health Share. I also happen to be a veteran, so I get some of my care at the VA. The DPCs, I think for me as a patient and for my family as patients, it's an outstanding fit. But I also agree with Dan that the right DPC will be a great collaborator. But just as with anything, you have to suss that out. You know, not every orthopedic surgeon is the same. You know, you have orthopedic surgeons that'll do 1,000, joints a year and have 0 infections. Then you have a guy that's right next to him that'll do 10 a year and 50% have infections. Those are not the same. And so in the same way that you would have to figure out, okay, who am I going to refer my patients to? You also want to figure out, well, who do I want to talk to see who might refer patients to me? Yes.
Is there anybody that you know of working with employers to try to find a capitated rate for their employees? So you're not going directly to the consumer, you're going through the employers and get your employees.
So the question had to do with going through the employers rather than going directly to the consumer, and do we know anybody that is doing that? I personally don't. In my practice, 56, we track these statistics in my practice. We, meaning me and the one other person in my practice, which I think we should talk about in a little bit. I'm a 2-man shop, or 1 man, 1 woman, okay? We do everything, answer the phones and so forth. But in my practice, 56% of my patients find me through YouTube. Another 38% find me through other social media channels. Those that don't find us through social media, almost all of them find us through word of mouth. I will tell you that referrals from employers or other physicians accounts for less than 10% of the patients that I see. And to be perfectly frank, the patients that I want are the ones that want me more than I want them, right? When I was a resident, I remember one of my attendings telling me, you should never want to do surgery more than the patient wants the surgery done. And the kind of scenario that we have set up in my practice fits that model perfectly.
Just to clarify, are you talking about DPCs who have these direct contracts with employers, or just any
Similar to that,
surgeons?
I mean, we're here, sort of representative of the subspecialty model, which is still in its infancy, but, so that's what we're talking about.
I don't know any, number one, I don't know many surgical subspecialists who do direct care, but I don't know anyone who has direct contracts. I think that's the valuable play for this, the really, high yield relationship that we do look for. I don't mind that. I think that's something that I'm trying to figure out how to crack that code, how to get in front of employers, HR, CFOs, and explain to them the value add and the value proposition. Some of the DPCs that I do network and market to, they do have some contracts. I don't think I've seen anything directly from that relationship, though. I know they do have some direct contracts with employers, but I think, like Dan said, they're usually just maintaining a lot kind of in-house and managing them before sending them to us.
Yeah, and in my experience, like I said, I have one DPC doc who kind of gets it, and so she'll bounce all her ortho to me. I bill her, and then she bills the company, so I'm not really directly contracted with them, even though the company's sort of paying for it in a way. But normally, like when I've tried that route, which I agree with Dr. Azude is probably the way to go, is like there are the companies that are forward thinking already usually have DPC, which obviously is good, right? I use that for myself. And so when they're talking about tacking you on for another $1 per member per month or whatever it would be, which I think would be really valuable, it's hard to sort of move the needle in that way. I've gotten close, but it's hard to kind of take someone and move it off because it's sort of all going through the DPC doc and they're managing it and they're like, well, I'm trying to save the employer. I don't know if I want to add it per $1 per member per month. Or you sort of kind of get, in my experience, I've kind of gotten close without really sealing it. But I think that is where things probably should go.
I mean, one of the values of a conference like this is it's aggregating people together that are sort of like-minded. And I just think that aspirationally, over the next decade, you and urology and cardiology and nephrology all figure out how to bundle together and carve that dollar out and then go to the employer, because that changes, that's the one piece to this whole thing from what Keith is doing in Oklahoma City at the Surgical Center to DPC that hasn't bridged that gap yet. And if you can do that, then you will undercut health insurance.
I agree 100%, and please don't misunderstand me. I feel very strongly that relationships with employers are going to be a key to sustainability in this model. And I think it's challenging for individual surgeons like ourselves to develop those relationships. I've been trying for years. I've gotten in front of a few employers, and the question I always get is, okay, well, that's great that you're offering this one service line, but what about the other 10 service lines that I need? And so that's where partnering with Misha Health and with Fair Market Health and others has the potential to be really valuable, because they're going to take all of us and aggregate us together and then be able to offer a comprehensive package that's tailored to the employer and that includes us. And one of the things I love about this model is that, like Sydney and like Dean, they don't come to me and say, Doc, this is what you're going to charge, and this is what we're going to pay you. In all of these cases, they've all come to me and said, Doc, you tell us what you're going to charge, and then we let the market decide whether or not that's appropriate. And if you're charging, $50,000 for, a tonsillectomy, don't be surprised if nobody comes. Okay.
But I just wanted to add to your point about what's the 10-year perspective. I think another component to that is probably transparently priced micro-hospitals. And you've got to have some place to take people. They've got to be able to stay overnight. They've got to maybe have ICU here. And if you can work on that end as well, this all kind of comes together.
Yeah, I think that's what Keith essentially accomplishes in a way with the brand of the Surgery Center of Oklahoma, right? He has multiple different disciplines, and that becomes the brand. I visited Keith 2 years ago and just for a day picked his brain on how he's done it. And he explains he's kind of like the triage almost, these employers or the TPAs, they call him, and then he kind of disperses it out based on if it's an ENT problem or a urology problem or orthopedic problem. So he's kind of that center hub, and you need something like that brand, like
Market ACO.
Exactly, just so.
Yes.
A question on the social media, is this stuff that you're paying to do, or is this free stuff to do?
Thank you. I have a marketing director, so you might say she's a subcontractor, so she's not actually an employee in my practice, but she does all the marketing for my practice. I send her videos, like video testimonials. We got like over 300 video testimonials on our YouTube channel. So this is one thing that, for those of you that are physicians, you got to get used to this idea that you have to advocate for yourself, okay? And so it took me a while to kind of really embrace this, but now it's part of our routine. And general rule of thumb is that when a patient comes in, if they're not pissed off at me, then I ask them to do a video. Okay, I mean that's the bar, And I say, look, we have we have a room that's dedicated. It's got a background. It's got a camera, and we say, look, can you just spend a couple of minutes? And we have 5 questions. There's one person in my office who knows what 5 questions to ask, and I tell her, look, don't box them in. If they want to talk about something else, let them go. And the marketing director will edit it into something that makes sense. Okay, but I can't tell you how many patients have come to see me who have said, I asked them, well, what made you decide to come see me? I saw Jane's story online, and that was me. Or I saw Jeff's story, or I saw Dean's story, or I heard the story from Mark, and that was me. And I started to cry because I said, maybe I can be your next Mark. Maybe I can be your next Fred, or fill in the blank. Those videos are really powerful. Like, we track the statistics on our videos. If I'm the one that's talking, maybe I'll get a few hundred views. If it's a patient who's talking, it'll be a few thousand.
I can say in my 2.5 years in this space, that's been my biggest learning curve. It's been the marketing. As a physician, as an MD, we're used to having positioning already. That's our degrees. That's the time that indicates that we spent. And so patients come to us, especially in that old traditional model. But in this model, you have to kind of get the message out. And this has just been a huge learning curve. I think you need professionals. Not only do you need to learn it yourself, both social media, traditional marketing, but you need professional marketing teams to some degree. And investing in that is super important. So I know we have 2 minutes left. So
yeah, I'll just say real quick. Yeah, I mean, if you're a physician doing it, like any modern physician, like you need to do that. You need to pay attention to your Google reviews. You can't do all the platforms, I'd say pick 2 at most that sort of fit your flavor of personality. And that's what I would do. So for me, like I do YouTube and LinkedIn, we do like 1-2 YouTube video a week, and then like 1 LinkedIn post usually a day during the week. And like just consistency and doing it for a long period of time will, if you're saying the right messages, will gradually build people. But you can't do all of them. You can't do like Facebook and Twitter. And I actually would avoid Twitter, but my 2 cents there.
You know, since we're just about out of time here, and I know there's a lot of you here, and I'm sure there are lots of other questions that we haven't had time to get to. I was hoping we were going to have an hour, and it turned out it was just half an hour. Speaking for myself, I am happy to have an extended discussion with any of you about any of these topics. You know, as one of my old attendings used to say, there's no such thing as stupid questions, only stupid people. So please bring whatever you have. I think I speak for George and Dan when I say that, not the stupid part, but the, the openness to these discussions. And then the other thing, I'd like to ask all of you a favor. You know, we saw that there were 18 people that signed up. I counted. There's almost 70 of you here out of the 500 people that are here. I mean, that's really humbling.
Yeah, thanks for coming.
And so I want to get a picture of all of us together. You know, I suck at selfies, but if you guys are open to that, you know, I'd like to do that. And you know, you'll be on LinkedIn later today.
Get in here.
Are we doing that right?
There we go. We'll be on.
Okay.
There you go.
Like that?
Yeah.
All right, everybody smile. 1. I got the top of my head. That's all right. I'm okay with that. Okay, any parting shots?
Yes. Okay.
All right. Well, thank you for your attention.
George, thank you.